Is this working? Oh, yes. Good morning, everybody. It's a very cozy session today. So please move up front. So we're all sitting up front. We don't have a lot of people yet. People will join. So I think we should start. So, um, someone has my program. I had my program. So, okay, great. I think we have all the presenters here, so let's get started. Good morning, everybody. Thank you for being at this session today. So the title of our session is National and Subnational Implementation, and we are part of the Universal Health Coverage Family Planning Track. So this is an important session because it takes us from all the theory we've been hearing about UHC and how it's important to actually discussing what is happening in country. And it's interesting that we're going to get kicked off with someone that's going to talk to us about Nepal. And I need to grab my notes. So we have four exciting presenters today. We're going to start with Dr. Om. Dr. Om comes from the Family Planning Association of Nepal. He is a medical manager and is also the focal point for IPPF Sprint project. So we're going to call Dr. Om to start, and then he's going to introduce himself briefly and then take us through his presentation. Thank you. Why are the slides not? Yes. Okay. We good? No, that's not yours.
Yeah,
Is that
it's
it?
mine.
Okay.
Good morning, everyone. Yeah, and I'm Dr. Om Maharjan. I'm working in Family Planning Association in Nepal since 2012 as a medical manager, and I'm also service provider and trainer of, comprehensive abortion care, vasectomy mini lab. I have also conducted more than 20,000 vasectomy mini lab, and since 2015. I'm also working as a project coordinator of Sprint project supported by OSTAID. So today, my presentation will be on uh, uh, effective engagement of affected people, population in community feedback mechanism during COVID-19 response for continuing of essential SRS service in Nepal. So this is the content of my presentation. So, first of all, background of the this abstract is accountability to affected population is a term used in humanitarian sector which recognize that the women, men, girl, and boys receiving humanitarian assistance are primary stakeholder of any humanitarian response and have a basic right to participate in the decision that affect their lives, receive the information they need to make informed decision, and to complain if they feel the help they receive is not adequate or has unwelcome consequences. And the picture we have taken is from IFCRC, which depict the number one is learning, to provide information, and third is supporting BCC, and the fourth one is supporting community to speaker. And as part of the core humanitarian standard, it needs to be addressed at the organization level as well as through coordinated effort across humanitarian sector. It put community at the center of our response. Accountability. Accountability to beneficiary is a core aspect of quality humanitarian response. Centered to accountability for service governance, in particular of health service delivery, is the community feedback mechanism. As part of SPIN project, the International Planned Parenthood Federation is supporting its member association to develop community feedback mechanism to be more transparent and enable community ownership of the response intervention. This is done through engaging community in the planning, planning, implementation, and monitoring supervision and phase. Yeah. Program intervention. In order to establish community feedback mechanism, just a minute. Yeah, in order to establish community feedback mechanism in each setting, PAN undertook the followings: identify the portal of entry and mode of engaging various marginalized group during the response intervention. Supported PAN branches on implementing community feedback mechanism based on the local context. Mentoring was provided to branch manager and headquarters staff, resulting in well-communicated mechanism for improved service quality and the consultative decision making. Yeah, methodology. To set up community feedback mechanism in multiple locations, EPAN utilized qualitative approach to inform EPAN branch manager on various possible options channel for two-way communication, which they could adopt for establishing community feedback mechanism based on the local context and resources. These include 4 in-depth interview with branch manager, 5 focus group discussion with service providers of the EPAN branches, and 12 FDGD with clients or service user from various marginalized group, which include youth, adolescent, HIV, PL-HIV, LGBTIQ communities. And these all were held in the randomly selected sprint-supported district of Banke, Janakpur, Kaski, Kabre, and Surkhet district of Nepal. And the technical and the field work to inform the setup community feedback mechanism was completed in 5 months period between September to January 2022. And results: maintaining meaningful engagement with community and functional community feedback mechanism are considered as the building block of the accountability. This report assesses how these 3 basic elements of accountability have been put in practice by EPAN. A, the information sharing in languages, format, and the media that are easily understood by marginalized group and the affected population. EPAN has enshrined the right to information in the client rights on SRH, which are displayed at all service centers, staff code of conduct, staff code of conduct, information and community feedback mechanism, and organizational commitment should be also adequately visible. EPAN has utilized multimedia for information dissemination and obtain feedback, including complaint via peer mobilizer, complaint telephone, hotline, interactive meeting, and Facebook. B, participation ensure our marginalized group engage meaningfully at all stages of the program cycle. Within the 2 tier of governments, the center or headquarters, and the B, the branch level. EPAN has youth center committee member, which enable youth-led participation, while no other marginalized group are structurally engaged to secure their representation, although functional relation with the national network are maintained. 3, complaint response mechanism is a part of the quality management, as it provides mechanism to amend serious issue, including fraud or breach of code of conduct, and systematically gather feedback on the quality of services. Complaint boxes, availability, and the client exit interview were periodically conducted at all service centers with the merit of literacy and subjective bias. EPAN branches held ad-hoc meeting with local community. Yeah, okay. Local meeting with local marginal group, which gave opportunity to provide feedback with immediate follow-up on action point with no documentation or assigning focal person for marginalized complaint, resulting in limited opportunity for learning and improved program quality. And learning. By consulting the community and the stakeholder, it is important to determine barriers in terms of feedback being listened to and acted on. While particular issue and resolve, lack of the systematic approach mean that communities are not aware of community feedback mechanism and difficult for humanitarian agency to take their response and disseminate. IPPP recognize the need to improve this and ensure the process was well institutionalized, following the recommendation for scaling up the feasible community feedback mechanism. Information sharing, use of interactive social media platforms such as Viber, WhatsApp, Facebook to disseminate information for the specific group communication, and the use of toil video messaging for each of these key population, including hearing, impairment, and illiterate. Periodic meeting with stakeholder, including the district chapter of marginalized groups, volunteer, model group, elected representative of municipal corporation, can provide a platform for sharing decision with limit timeline activity of follow-up. Upon adopt apps with functionality of the receiving complaints, suggestion, and feedback among the client marginalized group partners that upon seek to assist. B. Engaging marginalized group. Formal engagement with the marginalized group through their representative as invitee member in branch central committee for input and suggestion. Yeah. Yeah. The cursor is missing. So. Yeah. Yeah. Also, setting up complaint response mechanism. It is desirable that the complaint mechanism feedback have been multiple entry point for collection such as suggestion box, complaint box, telephone, electronic online platform, mobile apps, regular stakeholder meeting, client exit interview, smiley on the exit interview, and this is my presentation. Thank you.
Thank you. Please, thank you. Thank you very much for taking us through your work. And I think what we're going to do is to have the second presentation, and after that, we'll take questions. And we will be able to come back to this. All right? Thank you so much, Dr. So I'm going to call now Dr. Gansiam. He's a doctor of public health. He's an expert he's been working in the field for the past 25 years, and he's coming to us from ADRA, Nepal. He's the associate director for health at that organization. So please welcome Dr. Gansam to the floor.
Good morning, everyone. Thank you, my moderator. This is especially presentation is based on the last pandemic scenario, and that's especially impact to the Nepal family planning programs. The complete lockdown due to the complete lockdown due to the declaration of the COVID-19 pandemic led to closure, even the outpatient and the widespread fear to the COVID-19 transmission as an institutional setting globally as well as to the Nepal. This threatened to the progress made by the Nepal in healthcare and last 3 decades, such as the ANC, family planning, PNC, all have the impact. And you can see there around the 50% to the 18%, some services are the decline due to the pandemic scenario. This increased the maternal death by the 30% when the service, after the lockdown, the service are the closed down. The rollout, the interim guidelines at the health facility level to continuation of the reproductive, maternal, neonate, and the child adolescence program services during the COVID-19. The program intervention by the ADRA Nepal organized the virtual training to the interim guideline to engage the health workers for the continuation of the reproductive health as well as the family planning and all the services. Capacitated 1,497 health workers covering the 100% of the health facilities in 3 districts, one of the province in Nepal. The aim of the follow-up interaction was therefore twofold: to seek the feedback, understand the extent to which the health workers have been able to implement the interim guideline, and to provide the further clarification and support to the health workers as needed during this pandemic. Some methodology is clearly to intervention. This was the cross-sectional follow-up study and carried out using the quantitative approach. A study was conducted in 3 programs intervention districts. The data source were trained to the health workers who engaged rollout of this RMNCH interim guideline from the June to December 2020. A total 282 respondents were selected among the around the 1,500 using the probability and the proportionate size for the sampling. Among the 234 health workers from the primary healthcare center and the 16 from the hospitals, there were 32 health coordinators or the managers included in this study. Due to the COVID-19 pandemic, we looked no harm approach to collect the data remotely during the December 2020. The structured questionnaire were collected. ODKUs informed the consent from each selected respondent, and data was analyzed in the SPSS. Overall, the result for the orientation on the IG RMNC is threefold. The health facility had just screened and tried the services COVID-19 all the patients and the visitors. The majority of the pregnant women received the ANC services and utilized the delivery care services. Only 58% could protect the clients themselves from the cross-infection. Even after all the trainings, the fear was still there. Almost 100% health facility provided the family planning commodities such as the pills and condom after this orientation. The health facility providing these services after the interim guideline training, the ANCs, almost all the health facilities just started. The OPDs was already started. Family planning, 87% of the health facilities started. Self-abortion services, 56%. Immunization as a routine works, as well as to the PNC and home visit, resume as a regular. If you look the total result, the hand washing and sanitization of all staff, almost all the staff started for that, as well as the total using the PPE just for the 20% even after the training. Challenges faced and implementing through this one, especially the PPE is still the challenges based on some district, as well as the medical equipments and the human resources was as a challenge for after even the trainings. For the result, among the health facilities providing safe abortion services, only 16% started that's program. The majority, around the 91% of health facilities had hand washing and sanitization for the visitors, even the 100% for the healthcare workers, but for the visitors, still the 91% that was. Nearly 90% of health post in charge observed the changing after this training program, and they start the using for the PPE and the other sanitization process. After the orientation to all the hospital, they also started the ANC, PNC, SAS, as well as other programs as a regular basis. More than two-thirds health facility reported they were able to protect themselves and the clients cross-infection. Around the 90% of the health coordinators reported the changes had happened after the RMNCS training immediately. The most respondent reported that they had the supplied all the COVID-19 related commodities to the health facilities, less stock or overall the programs. The main lesson learned, the main drivers to the interim guideline rollout after ever the national, subnational programs, managers, and providers. Follow-up for the interview conducted with them clarified so them the orientation on the guideline was timely and useful to in terms of the context. The majority of health workers are provided service per RMNCH interim guideline as a high range. 84 to 96% of health workers have absorbed the changes after this orientation. In a context where the service were functioning at the minimum capacity or within the environment to the fear, the guidelines provide the clear direction for the health facility peoples. Role of the government is key providing to the health system from the unexpected shocks and stress such as the pandemic condition. Thank you very much to all.
Thank you. We're going to ask you to stay here, Dr. Gansiam, and we're going to call back our presenter, Dr. Om. Do we have any questions in the audience? We can take one or two questions before moving out to the second set of presentations. And I guess maybe I'll ask you a question. So Dr. Gansiam has presented on COVID and how they were able to quickly create a mechanism to keep healthcare workers working. And you had presented us on the community engagement. Was community engagement impacted by COVID at the time? And did you put together something like what Dr. Gansiam has presented in your case? And for Dr. Gansiam, the question is more, have you done anything, because the healthcare workers are also a community, so have you done any extra or any different services or have you used any other tools to help the community health workers get back to what they were supposed to do? So do you want to start with the first question? Yes, so the question is, because you worked on community engagement and we just out of a pandemic, were there any implications during that in the work that you did? Did you do anything special around that time to make sure that community engagement was continuing? Can you go to the mic next to you, please? Oh, you can come here.
Yeah, you can come here.
Yeah, we have at the time during COVID-19, we use a community engagement like mothers group and youth volunteer, and also for LGBTI community stakeholder, so that they can inform all the service available in FPAN. So like this, we can utilize communities. Yeah.
Yes, thank you for the queries. And especially when we started to the training, we do the both as a hotline services to the healthcare providers. If they have any kind of the confusion, or if they need to be the more clarification of this service resume. So that's the hotline services to them as a open access for the telephonic conversation, as well as we have also sent some human resources as a additional to them when they have some complication, and they can be as a backup support to the health workers. Thank you.
Thank you. Thanks to both of you. Do we have any other questions in the room. We are a cozy room today, so if there are questions, please feel free. If we don't have any questions, again, we'll go ahead.
Thank you. So I'm being from a Nepal also, so I can relate with the studies that has been presented. So I just have one question for Dr. Om. So you said that you are using the social media to reach the group. So regarding the scenarios of the district that you have given, I think with everyone is covered.
So you need to speak louder.
Yeah.
So regarding to this social media group, how you were saying that you were reaching to the marginalized population and indigenous population as well as
Yes.
Okay, so regarding so you said that you are including these marginalized population in your community engagement as well as you are using the social media also, but it's kind of like distracting that the marginalized population, as we can see that the marginalized population are below the poverty line and you are using the social media. So how did you cater these marginalized population using the social media? Because I think it's kind of like regarding the Nepal scenario, the marginalized indigenous population, they doesn't frequently use these social medias, and you are saying that you are catering the marginalized population. I just want to know
So
that
we,
how did you?
yeah, we have also Facebook pages. Also, I mean, we have also frequently meeting with the stakeholders, like marginal LGBTI community, and also with PLHIB groups, like and so through them we are communicating with grass level of the marginal population.
Thank you very much. Thank you to both. Thanks to both of you. Please, we're going to now welcome our next two presenters. Sarah, you are next. So Sarah Britton-Gam comes to us from FHI 360. And Sarah, you have the floor to tell us a little bit more about your experience in family planning and your presentation.
Great. Hopefully the slides will come up. Looks like we're having a little bit of a technical issue, but thank you all for coming. My name is Sarah Brittingham. I'm a Senior Technical Officer with FHI 360. I'm currently working with the Research for Scalable Solutions project. And the assessment that I'll be presenting to you today is funded by USAID through Research for Scalable Solutions, an implementation science project. And you'll see the names of our partners on that project at the bottom of this slide. The team included myself, Trinity Zan, can you wave? An Associate Director in Research Utilization at FHI 360, and our veteran medical advisor, Dr. Irina Jakobsen, who I think it's worth noting, given the topic of the conversation we'll have today, has been an author on a lot of the global guidance documents around family planning. So on the next slide, just remembered that I'm supposed to advance them. I'll quickly kind of go through an overview of our process that we used for this content analysis, talk you through some of the key findings and recommendations, and then share with you how we are disseminating what we learned. So let's start with just kind of thinking about what already exists. So digital technologies have really kind of stepped up during the past decade, and especially I think during the pandemic, to meet the contraceptive needs of users. Where in-person services have not necessarily been able to. So we've seen a lot of new tools coming out, tools adapting, and there's some great resources out there about the interventions that exist. So we have the Digital Health Compendium, we have the Digital Health Atlas, and then there's great resources about the evidence that exists. So we have the 3 different high-impact practice briefs, which are all focused on digital health. But with this assessment, we were really seeking to answer the question you see at the top of the slide. So what is the quality of the tools that exist? So our primary objective here was to assess the content of client-facing family planning tools for both comprehensiveness and accuracy. And we did that across 11 content areas. And these were really selected to kind of reflect the core elements of informed choice. And ultimately, what we wanted to do was provide a list of tools that had been vetted. So these were the tools that kind of had the highest quality content. And we wanted to communicate some trends in the content. So where was the content better, and where did the tools struggle to have accurate or comprehensive content? So in this presentation, I will focus on the latter. So we're really going to look at the quality of the content. So briefly, I'll just speak about our process. So we started with a landscape analysis of both provider and client-facing tools. And then we whittled it down to actually just 11 tools that we ended up including in this content analysis based on the criteria you see here. We developed and applied a rubric to analyze the content, and then we used that to assess the tools and then provided feedback to each of the tools so that they could then later improve their content. And ultimately, of course, disseminating like we're doing right now. So here's an image of our rubric and the kind of information that went into it. So the information needed to support high quality family planning content and tools is very much out there, right? We have the family planning handbook, we have medical eligibility criteria, we have tons of resources, but they're not exactly designed to feed straight into digital tools, right? So we had to design a rubric to really help our medical advisor apply what we knew to kind of assess these tools. And so on the next slide, I will just start to share a bit about our results. So as I shared, we'll focus really on the trends in the content areas. And due to the limited amount of time we have today, I'm really going to focus on the 4 content areas where the tools provided the least accurate and least comprehensive content. And I will, of course, share the names of the tools that we are recommending based on our content analysis. Before that, and you'll probably thank me for this later because I think you're going to be seeing this platform throughout the conference. But I would love to get your thoughts on this. So has anyone used Slido before? It should be easy enough. So you can either open up, I keep wanting to go to the slides, www.slido.com and enter this code, or you can scan the QR code. And I would love to kind of get your predictions about the content. So my question to you is, in which of the content areas did tools provide the most accurate and comprehensive content? And you'll see multiple choice answers. Is anyone there yet? Is it working? How, you got it? Okay. No questions. Okay. So raise your hand if you think it was non-contraceptive benefits. And this is the complete list, but I'm just going to give you 4 choices. So do you think non-contraceptive benefits was the least accurate and comprehensive? Anyone? No? What about discreteness? Side benefits? Okay, 1, 2. Side effect management? Okay. All right, you guys did well. So that was the answer. So interestingly, none of the tools actually addressed side effect management. That was completely absent. Let me get back to where I was. And sorry, that didn't work. So on this graph, you're going to see the scores of each content area. So this is really an aggregation of each content area for all of the tools. So again, this is kind of the trends by content area. So again, I won't focus much on the methodology that we used today, but we assessed each tool's content area and then assigned a score. And it was basically a categorical score. So it was based on the amount of omissions, inaccuracies, or incomplete descriptions. So the lowest possible score here was -1, so that's where you see side effect management. The highest was naming all modern methods, which we would hope all the tools would do. So now I'm going to go into a little more detail about that and then share the information by content area just to give you some of the key takeaways. So on this graph, what you see is on row 1, or really row 2, I guess. So these are the number of tools that included any information about that content area. So here you see side effect management was not covered. On the second row, those are the tools that had the higher quality content. So for example, if this number is on the high end, that means that those tools had just 0 to 1 omission or inaccuracy. Row 2 is kind of middle of the road, 2 to 3 errors, and then row 3 is more than 3. So you can see here, I circled in red where it was more than half of the tools had more than 3 errors or omissions. So really what you can see here is that on this end, we've got discreteness, mechanism of action, instructions for use, side effects, effectiveness, and non-contraceptive benefits that were kind of the problem areas for tool content. So So what exactly do I mean when I'm talking about inaccuracies or omissions? I think it's worth saying. So just an example here. Inaccuracies, several tools included outdated information about the duration of protection of implants and IUDs, which points to one of our, this is a bit of a spoiler alert, recommendations that I'll give, which is really to maintain up-to-date information, use the global guidance. I think many of us will see the FP handbook has just been updated and is being released, so refreshing our content is a really important piece of maintaining quality in digital tools. And then for an omission, we noticed that guidance to use dual protection was actually frequently not present when we were talking about fertility awareness methods, which seems like a big gap. Okay, so moving into our first content area, I'll just explain that on each of these next 4 slides, I tried to include an example of tool content. And this is actually kind of ideal content or high quality content that we saw in our assessment. 5 minutes, okay. So for non-contraceptive benefits, we assessed whether the tools included this by method. This is really an emerging area of importance. And what we saw was that 7 out of 11 tools had 3 or more omissions there. So really struggling to mention these things like improved menstrual regularity, reduced cramping and pain, protection from certain cancers. And a closing recommendation here is that covering these benefits in detail can really help to reduce harmful myths and misconceptions, and then it should be included systematically in tool content. Moving on to effectiveness. So 8 out of 11 tools included 3 or more inaccuracies or omissions related to effectiveness. Here, we were really just looking at typical use, so we did not require that each tool have also perfect use. So just sharing accurate numbers for typical use. On the right, you'll see some content from Love Matters, which is really great. So they even went into explaining the difference between typical and perfect use. And then they went into kind of a chart explaining for each method what is the typical use rate. And probably all of you, I think I'm preaching to the choir here, but some methods like an IUD or an implant have, of course, really close between typical and perfect rates, but there are others like condoms that really don't. And so it feels really important that tools share this information accurately. Moving on to side effects. So only 1 of 11 tools included correct and complete information about side effects. Information about the side effects of oral contraceptive pills was inaccurate or incomplete in 10 out of 11 tools. So that's pretty astounding, right? Research shows that when women want to avoid pregnancy, their concerns about the side effects may prevent them from using a method, or it may even lead to discontinuation. I'm going to skip this data, but users also can be overloaded. If you're in a counseling session with a provider, getting tons of information, choosing a method, this might be the piece where you kind of tune out for a second, right? So we feel like it's really important that digital tools can kind of complement that interaction with providers and share that information. Moving on to instructions for use. So again, an area that was a struggle. So 7 out of 11 tools had 3 or more inaccuracies. Interestingly, the instructions for oral contraceptive pills, which I think many of the women in here probably, if you've used it, it is a little complicated, but that information was often inaccurate or incomplete. IUDs, fertility awareness methods, and condoms frequently contained errors or omissions. Am I done? Okay. So I'm going to quickly just share that we have some very basic recommendations. I already shared the first and second. External medical review, really important. That's how we garnered all this information. And of course, there's great tools for adaptation. At the front when you walked in, I hope you grabbed our checklist. So that is really where we synthesized everything we learned and are trying to help people who have digital tools, are developing content to kind of not make the same mistakes. So we put lots of tips in here, like you see, to really guide the user through this process so that it's not all dependent on having an external medical reviewer. And ta-da, these are the tools that we were able to recommend based on our content analysis. So one of our kind of recommendations was also, let's not reinvent the wheel. There's these great tools out there that can be adapted. They're available in, I believe, 9 different languages across all these countries. So just kind of information for you to have. And thank you very much.
Thank you, Sarah. Thank you for helping us catch up with the time. I really appreciate. So we're going to hand over to Mohammed Ishaki, And Mohammed is the Director of Monitoring and Evaluation and Learning at Pathfinder. Mohammed, yes, you have the floor.
Yeah, thank you. Thank you for joining this technical session. And my name is Mohammed Ishaq. I am from Pathfinder, and I don't want to eat my own time because I don't have a, we are already, and I have a bit longer presentation, so please bear with me. So today I'm going to present one of the flagship program funded by the Bill and Melinda Gates Foundation. Naya Kadam, the topic is the Naya Kadam to increase post-pregnancy family planning through public and private partnership across 2 provinces of Pakistan. Naya Kadam means a new step in English. So early and close pregnancies and high fertility rate, 3.6, threaten the health and well-being of Pakistani women, including their newborns and families. The latest Pakistan demographic and health information revealed that 34% of birth occurs during within a birth interval of 24 months, and 64% unmet need for family planning during first year of postpartum period. And of the total pregnancies, 47% are unintended pregnancies, and out of those, 55% ends as induced abortion. So giving all the high unmet need, high rate of induced abortions, high total fertility rate, Pathfinder implemented a 4-year-long project, which was funded by the Bill and Melinda Gates Foundation, and it was a consortium project with public and private sector. So Naya Kadam took a holistic approach towards post-pregnancy family planning and strive to improve skills of both public and private sector network and for the in-service and pre-service service provision. It also increased access to quality postpartum family planning, PPFP, and post-abortion family planning, PAFP, services through a total market approach and in-depth community mobilization and engagement. Pathfinder and its consortium partner also strengthened the data management system and information system. So Pathfinder and the consortium Naya Kadam basically took a holistic approach from top to bottom. So Naya Kadam, as I said, a consortium of program partners led by the Pathfinder, took a total market approach, working with public and private sectors. Naya Kadam cuts across all levels of the health system by generating demand, improving access and quality of service delivery at the community and facility levels, strengthening integration, multi-sectorial collaboration, and health information system at the provincial level. So the project aim was to increase access to high quality PPFP, post-pregnancy family planning, including both PPFP, postpartum family planning and post-abortion family planning, with a focus on young women aged 15 to 24 in Sindh and Punjab provinces of Pakistan. These were the consortium partners. Pathfinder led the consortium and provided technical support to the government in order to enable the environment, the policy environment, and advocacy environment. Green Star is a social marketing firm affiliated with PSI, NCMNH, Ahang, IPAS, and Shirkatgah. These all 5 partners played a tremendous role in ensuring the access to quality family planning and post-abortion and postpartum family planning. So how and where we institutionalized post-pregnancy family planning. So Pathfinder and consortium partner institutionalized post-pregnancy family planning through co-creation with partners, health system strengthening, community engagement, and total buy-in and ownership from the government. And where we institutionalized postpartum and post-abortion family planning in the overall provincial health system, including the health workforce, Pathfinder and consortium partner, the Naya Kadam, strengthen the capacity of the frontline health worker, strengthen the service delivery through public and private partnership in ensuring and expanding the service delivery network, NACADAM also upgraded public health facilities in order to enable them to provide quality family planning and post-abortion and postpartum family planning services. Also strengthen the DHIS, District Health Information System, to integrate the PPFP and PFP indicators in their system, and community engagement through community-based organization, youth champions, and private sector health workers. And last but not the least, leadership and governments at the policy and advocacy level. Co-creation with partners. So one of the partner, Green Star and Pathfinder, developed a comprehensive integrated pre-service and in-service package for all cadres of providers. By integration means gender, youth, AYSRH, all included in that clinical technical service package, training package. Strategies to guide FP interventions. So we also established, NACADAM developed a gender integration strategy and AYSRH service strategy. Private health systems for postpartum family planning, post-pregnancy family planning. So Green Star Social Marketing, GSM, integrated postpartum and post-abortion family planning indicators in their health system. They also adopted training modules for all private sectors in order to ensure and standardize the training provided by the government to their field staff and private sector to their field staff. So there should be an harmonized. So we ensured that standardization as well. Capacity strengthening, NACADAM strengthened capacity of community-based organization to conduct or to lead the community mobilization and demand generation for the PPFP and PFP services. We also, NACADAM also trained the youth champions to generate the demands. Government buy-in, so PFP, post-abortion family planning policy endorsed by the government, post-pregnancy family planning also endorsed by the government of Sindh. The lady health worker strategy revised and endorsed by the government, and the first dose of injection, the Sahana Press, is also the guidelines and checklist endorsed by the government. We also revised the Regional Training Institute curriculum in collaboration with WHO, World Health Organization, and Pakistan Nursing Council, and it was also endorsed and approved by the Ministry of Health. So these are some snapshot why government owned this project, because they revitalized their monthly district level committee meetings. They also co-convened the PPFP subgroup meetings and task force meetings. At the strength and service quality level, NACADAM established e-learning and digital labs at all the intervention districts, implemented quality assurance framework to ensure the quality of services, and also implemented supportive supervision and mentorship model at all the district health. So NACADAM integrated PPFP in 406 public health facilities and 600 private health facilities. NACADAM strengthened the capacity of health workforce. More than 7,000 health workforce were trained on quality family planning and post-abortion and postpartum family planning. NACADAM also upgraded around facility-based 1,680 service providers. NACADAM also established PPFP skill labs, a total of 10 skill labs established at different health facility levels. NACADAM upgraded around 250 public health facilities in order to enable them to provide PPFP and PFP services. NACADAM also integrated PPFP and PFP indicators into DHIS, because we all know that the tracking and monitoring of the PPFP and PFP services is a big challenge for the DHIS, and most of the system focused on the family planning instead of the holistic and subgroup as well, like PPFP and PFP. And it is already a evidence-based strategy. It is also one of the high-impact strategy to provide family planning postpartum and post-abortion duration. We generated around more than 150 40,000 clients. We provided services to 140,000 women, PPFP and PFP services. And we also provided long-acting reversible contraceptive to more than 100,000 women during the entire project. Community engagement through the trained youth champions and community mobilization organization, they generated 1,000 referrals for the health facilities, and around 39,000 women were counseled by the trained LHWs, and they conducted more than 70,000 community support group sessions. We also developed and rolled out the social and behavior change communication. It was a holistic and very demand side generated social and behavioral change communication. So as part of COVID strategy, Naya Kadam implemented a SBCC campaign, and it was approved and endorsed by the government of Sindh and Punjab. Through this holistic SBCC campaign, we reached out more than 2.2 million, more than 2 million people through mass media dissemination and through local vehicle announcement. And we reached around 6 lakh people through SMS-based social marketing campaign. And 1,20,000 people reached through mosque announcement. So key achievement, primary and empirical evidence suggests that the activities and interventions were carried out under Naya Kadam were able to facilitate increase in postpartum and post-abortion family planning uptake across all public and private health facilities. The evidence also suggested that the Naya Kadam was able to bring about a positive increase in both PPFP and PFP. The number of beneficiaries for PPFP and PFP and large services were overachieved in comparison with the project outcome. Naya Kadam developed new policies and training packages that includes COVID-19 response strategy, curricula for health, community health workers, training manuals for healthcare providers, community outreach workers, and also developed the gender and AYSR strategy that was endorsed by the government. So the long-term impact, the development and advocacy for policies of PPFP and PAFP remained a key achievement under this project because Naya Kadam was able to integrate that indicators into the DHI system so that we can track and monitor the progress towards the PPFP and PFP. Sustainability, as I said, the major sustainability was concerned with measuring whether the sustainability basically concerned whether the project or the benefits of Naya Kadam project are likely to continue beyond the life of the project. So, it was seen that this DHI's work is ongoing process and ongoing system that cater and collect the data on PPFP and PFP. So it remained sustainable at the provincial level. So conclusion is the evaluation carried out by the Contact International concludes that the Naya Kadam project can be labeled as a successful project considering achievement of all planned intermediate outcomes by the project within the planned budget. The success of the project can be largely attributed to Pathfinder's and consortium decision to take the holistic and total market approach towards post-pregnancy family planning. So recommendation is, one of the recommendation came from the evaluation is oversight mechanism needed to ensure PPFP and PFP policy implementation because Naya Kadam developed the PPFP and PFP policy, but its implementation is a challenge. So there should be a mechanism to implement at the field level. DHI's intervention should be scaled up to other provinces as well to track and monitor PPFP and PFP data at country level. So we integrated, Naya Kadam integrated the PPFP and PFP in 2 provinces. So other 2 provinces should also be adapted the same strategy to track the data at the country level. Functional integration between the health and population department should be needed. They should sit together in order to strategize and see the supply chain and other issues. Skill labs for post-pregnancy family planning, clinical and counseling for capacity building of healthcare providers should be sustained and scaled up. Lady health worker interventions for referral and first dose of injection, Sienna Press, needs to be scaled up to all districts in a phased manner, obviously. Parents and community influential, especially teachers and religious leaders, should be sensitized on AYSRH issues along with youth. So we train the youth, bulge of youth, but parents and teachers should also be involved. So thank you so much.
Thank you, Mohammed. So we're going to ask Sarah and Mohammed to stand up there and ask if there are any questions for them in the room. Please go ahead.
My question for the it's a very interesting presentation, and it's basically project focus for project evaluation type of study which I found. And just my question, first question is who is the healthcare provider who are providing the like a post-abortion family planning and the post-pattern? Is the health provider the doctor, or is the health provider the staff nurse or the auxiliary midwife? And my second question is how do you ensure their quality, like to provide the services in the health facility? That's my two questions. Thank you.
Right. Thank you for asking two separate questions. So those who were trained on postpartum and post-abortion family planning services were included mid-level providers, mainly nurse, lady health visitors. So these all were the community and mid-level providers, not the doctors. And the second question about the quality. So we developed a comprehensive quality assurance framework and implemented across all districts with the support from the government of Sindh, Health Department of Sindh and Punjab. And we rolled out it across all health facilities. We went to the clinics and observed the 7 major components like side effect, infection prevention, counseling skills, all that on a quarterly basis. And then we analyzed that data. So there were cutoff points of the overall quality assurance scores. Those who scored less than 70% considered as a red zone, and they need to provide a refresher training to ensure the quality and all the infection prevention. And those who achieved score from 70% to 80% marked as amber, like they also need mentorship and on-job coaching and services. So these were the criteria to ensure the quality of services, and those all the providers were the mid-level. So I hope I answered the question.
Yeah, one more question. Like I was also impressed with the holistic approach you were taking, including the advocacy work for enabling environment. But also looking at the project level, there was a huge consortium partners, and given that the donor was also engaged. So was there any kind of evaluation, like cost-benefit analysis or some CYPs kind of impact assessment done?
Yeah, that's a great question. Due to but major data collection issues around in Pakistan, so we initially designed a robust baseline and endline survey to measure the impact of all these interventions on the community level. But due to some major constraint and challenges faced by Pakistan in terms of data collection, so we dropped that methodology. But we evaluated, hired a third-party firm, Contact International. They carried out an robust evaluation from the perspective of the program evaluation, audit perspective, and all the operation perspectives. So they did some cost benefit analysis like VFM, value for money analysis, and it was they adopted OEDC criteria, DAC criteria, development assessment criteria, to evaluate that project. So it came out from the evaluation that this project done beyond the scope of work as well, because COVID hit in 2020 and 2021. So we revitalized, or we remodeled our program strategy within the ambit of the overall project. So we, in fact, delivered beyond the project. So it showed that we delivered within the value for money framework. And cost per CYP is very low as compared to the standard $2 or $3. So it came out that CYP was around $1 per client.
We have other questions? Yes, go ahead.
Thank you, Sarah and Mohammed, for a nice presentation. I just had one question for Sarah and some question for Mohammed. So, Sarah, my question for you is that you are starting this, digital platform for the family planning information. However, do you have any, recommendation, or have you a future plan that how you are, because digital platform, it's kind of to the people who have access to the internet and resources. However, there are so many people who doesn't have access to the technology. So do you have any, recommendations, or your future plan that you can reach this digital platform to the local people also? So
Interesting. So thinking about assessing the content that is being given to folks outside of digital platforms?
yes,
Yeah.
yeah.
I mean, I think that's a really important point you raised, right? Like, how can we assure the quality in various interactions? Unfortunately, I don't think that the resource we pulled together would address that well, although I do think it could be applied really well to any written content. So I do see that it could contribute in that way to kind of assessing, for example, guidelines. And, one of the tools that we assessed actually even included guidelines that were for pharmacists to be using in their interactions with youth. So I think it's just so important to advocate for high quality content. So I appreciate that question. And
Thanks.
I hope I addressed it okay.
Thanks a lot.
I'm sorry, we have to quickly move on to your last question.
Yeah, okay.
For the panel, because we have other people who use the room. We're not at time yet, but please.
So I had a list of questions, but I'll just ask one question. So my question for Mohammed is that how did you ensure, it's because for the public sector, there is government who is looking for the quality perspective, but for the private sector, there are no any, governing body who is looking for the quality, and for, I think, regarding the side effect management and everything, there is the lack in the private sector. So how you are ensuring that the services that are provided to the private sectors are of the quality services, as well as if there are any complication or side effect, how did you ensure that it has been managed effectively? As well as adding to that question, no, it's okay. No, it's okay. So adding to that.
Thank you. Thank you. Let him
Yeah, sure.
respond to that. Thank you.
I'll quickly answer that question, because Pathfinder is not a service delivery based organization, so we did not do anything in the field level. That is why we included the Green Star Social Marketing firm, who is basically doing the field work and all that. And they have their own criteria, like we Pathfinder developed for the government sector. So it is similar quality assurance framework is being implemented in the private sector, like GSM. So they adapted a large anonymous donor-funded checklist, developed that checklist, and DKT International also developed some quality assurance checklist. So they combined all together and developed their own in collaboration with the PSI. So they used their own system to ensure the quality, and they were guided to report or provide the information on the quality level information to Pathfinder, so that we can gather information from private and public and compare the quality stuff.
Thank you. I want to ask everybody to really have a round of applause for our presenters. Thank you so much. We are time. I just want to make sure that we leave this session with two key things. I think we were supposed to look at subnational and national implementation, and that's what we did. Thanks for the colleagues out of Nepal who really introduced us to their community work, as well as to what was done with community health workers. And to the last two colleagues who were able to take us through a holistic program in Pakistan that gave us a good overview of all the components together and the impact we have when we work at scale. And to Sarah for talking to us about the tools that could be useful and how we should think about designing the tools to make sure that we have effective use. So thanks to everybody for a great session and for taking the time to being here today. Thank you. Thanks to all of you.